Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we will continue talking about neonatal problems. The subject of our talk today will be about birth injuries and trauma, which is a problem that occurs shortly after birth or immediately after birth. At the end of this lecture, you should know which baby is at risk for this birth injuries. In another way, what are the risk factors for this problem? Second objective is what are the types of birth injuries? What are the forms of these birth injuries? And of course, we need to know the diagnosis and the treatment for these injuries and trauma. First of all, what is meant by birth trauma? In another way, what is the definition of birth trauma? It is the injury to the fetus, to the infant, and this injury is resulting from either mechanical or anoxic trauma, and sometimes mechanical and anoxic trauma had occurred on the same time. And this trauma is occurring during labor and delivery. There are many risk factors for this problem. The risk factors may relate to the mother, may relate to the fetus himself, or sometimes may be related to labor and delivery. The maternal risk factors are the mother may have some problems that interfere with normal process or normal duration of labor and delivery, like pelvic abnormalities, or she may have cephalopelvic disproportion. Primary mother is also liable to expose to birth injuries and trauma more than multi, and if the mother has oligohydramnios, also this will increase the incidence or frequency of birth injuries. Some factors are related to the fetus, like macrosomia, when the size of the baby is large, his body weight larger than 4 kg. Prematurity is also a problem that is associated with birth injuries. The picture in this slide shows premature baby. The baby with hydrocephalus and other fetal anomalies are liable also to have birth injuries. It is very important for labor to pass normal duration and no complication to be associated with baby who is free from these injuries. When there are some problems related to labor and delivery, this may result in a problem of birth injuries. An example of these factors related to labor, vaginal breech delivery, shoulder dystocia, malpresentation, for example, oblique or transfers, abnormal or excessive traction during delivery. Of course, instrumental deliveries like forceps and ventures are highly associated with birth injuries. Sometimes this problem may result from resuscitation. Some trauma may induce to the baby during doing resuscitation for him. A prolonged labor also is a risk factor for development of birth injuries. This is a picture of infant who is large for gestational age when the body weight is greater than 90th centile. Thus are liable to have birth injuries, mostly in form of Erb's palsy and others, of course. What is the diagnosis of this baby? This baby obviously has abnormality when you look to his face and head. it is easy to be diagnosed. Let's know the types of injuries. What are the types of birth injuries and trauma? Cranial injuries, when the injuries are limited to the cranium. Peripheral nerve injuries. Visceral injuries. Skeletal injuries. Muscular injuries. So there are different types of injury. First of all, we will talk about the cranial injuries. And there are many types of cranial injuries, like caput succedaneum, cephal hematoma, subaponeurotic hemorrhage, subconjunctival hemorrhage, retinal hemorrhage, sometimes laceration and bleeding over the skin. And sometimes these injuries occur deeply in a form of intracranial hemorrhage. Caput and cephal hematoma are common birth injuries. Caput succedaneum is a swelling under the skin of the scalp. It is different than cephal hematoma. Cephal hematoma, from its name, hematoma means bleeding, and this bleeding is under the scalp. And both these conditions are related to pressure on the baby's head during birth. And both of these problems are usually harmless. Let's see this diagram. You can know that the name of this bleeding according to its site or its location. A bleeding under the skin is called, not bleeding, sorry, swelling, edema under the skin is called caput, while under the periosteum is called cephal hematoma. Now we want to know, how do neonates with these two problems present? In another form, what are the clinical features of a neonate who is suffering from these problems? First of all, he will present with a swollen scalp. Let's hear this case scenario. A 2-day-old male neonate. He presents with a scalp swelling. This is the presentation. We ask about the history of the mother. The mother is para 3+0. She had no antenatal care. The delivery occurred vaginally, but the process was prolonged and complicated by cervical dystocia and maternal exhaustion. Resuscitation was done to the baby, but he became well and he started breastfeeding 1 hour later. On examination, the baby looks well and there is soft swelling on the scalp. The swelling extends over the midline. When we press on this swelling, dimple is formed. The other part of examination is normal. He has a clear chest, soft abdomen, intact reflexes. He is well. This is the swelling over the scalp. It is soft. When the finger is introduced, dimple will be formed. This is another picture showing to us swelling over the scalp. Again, this is another view showing to us swelling of the scalp. This is another picture of obvious dimple, which is introduced by pressure on the scalp. Dimple means there is edema. So the diagnosis now is very easy. It is a caput succedaneum. Why? What are the points? In another way, what are the points in history suggestive for this problem to occur? There is a risk factor. The labor is prolonged. Resuscitation was done. The mother was exhausted. The swelling across the midline and over the whole scalp, not only on one side. And when we press by our finger, dimple is produced. There is pitting edema. Now, we diagnose the problem. How can we treat this problem? What is the treatment of caput? No need for intervention. It will disappear spontaneously, but the mother needs some reassurance that it's a benign condition. The baby will become well after time, a period of time. So, let's discuss this problem again. The caput appears as diffuse edema or sometimes ecchymotic hemorrhage of the scalp soft tissue. So it is a type of soft tissue swelling. Usually it involves the presenting part of vertex delivery. As we know from the previous scenario, the mother delivered vaginally. And the presentation at the time of delivery was vertex. So this is edema over presenting part, which is a vertex. It is usually associated with molding of the skin, skull bones. And it appears at birth and disappears within the first few days, and no need for interference. Sometimes edema is not only consisting of fluid, but sometimes there is bleeding, edema and bruising from venous delivery. This lesion is called chinon. You can see well, this is the scalp. There is a red to blue color over the scalp. This is bruising. Again, the etiology is same as a caput. Sometimes when the presenting part is not vertex, for example, face presentation. Also, during passage through birth canal, bruising may occur to the face. Look to this face, looks blue and red color. There is some areas of redness over the face. Now, we will hear another case scenario. You need to listen well to this case. Now we have 2-day-old male. Also, he is presented to us with a scalp swelling. We assess the history of the mother. She is para 3+0. She had no antenatal care. Type of delivery is vaginal. Labor is prolonged and complicated by cervical dystocia and maternal exhaustion. The baby needs some resuscitation, but he becomes well and starts breastfeeding 1 hour later. So the history at the beginning is the same as the previous case. But now you can see the physical examination is a little bit different. It reveals a well-appearing child. He looks well. But there is a swelling of the scalp, and this swelling involves the parietal regions, while other parts of examination are normal. He has clear chest, soft abdomen. Neurologically, he is intact. This is the picture of this baby, swelling over two parietal areas. Sometimes the baby can present with the swelling of the parietal area on one side, like this baby. So, what is the diagnosis? The diagnosis will be cephal hematoma. So, we want to know the suggested points in history that help us in the diagnosis of this problem. There is a risk factor. Mother has prolonged labor. She is exhausted after delivery, and the baby needs some resuscitation. This is the history. In examination, the swelling is not crossing the midline, and there is no pitting edema. Those 2 points are different than caput, which cross the midline and has pitting edema. So, after knowledge of diagnosis, definitely we need to treat this problem. How can we treat this baby? Again, he needs no intervention. No need to aspiration of this blood, although it is a hematoma, but no need for aspiration. Only we need resuscitation of the family, but this baby need follow-up, because we need to follow some complications that may occur. We will continue talking about this baby. The mother of this baby was reassured. She discharged home, but 2 days later she came back with her baby. She wants her baby for rechecking. On examination, we find that the baby is pale and jaundiced. So, this baby with cephal hematoma has some complications. So, what complications did he develop? He had developed anemia and jaundice. This is a picture of a baby with bilateral cephal hematoma, our previous baby in the previous scenario. He is jaundiced because he was put under phototherapy, so the eyes are closed. So, cephal hematoma is a swelling which is caused by subperiosteal hemorrhage. So the location of fluid is different than that of caput. It is limited to one cranial bone and does not cross the sutures. Sometimes it is presented with skull fracture and sometimes alone. It is not presented at birth, but it is visible in the second or third day after birth, and also it takes time to disappear. It may be associated with large amount of blood. When there is large amount of blood, so anemia may occur, hyperbilirubinemia may occur also. We need not to aspirate this blood because this will facilitate spread of infection. Conservative treatment is needed only. But when he develops anemia or jaundice, he needed treatment according to these complications. These are pictures of babies suffering from cephal hematoma. This one has bilateral cephal hematoma, this unilateral, and this is unilateral. There is another bleeding called subaponeurotic hemorrhage or subgaleal hemorrhage. Another type of birth injury. What is meant by subgaleal hemorrhage? It is blood again, as cephal hematoma, but the location is little bit different than cephal hematoma. It accumulates between the epicranial aponeurosis of the scalp and the periosteum. It crosses the suture line, but cephal hematoma does not cross suture line. Large amount of blood may accumulate in this type of hemorrhage, and this may lead to severe hypovolemia. So this type may be lethal. And there are some risk factors behind this type of hemorrhage, like coagulation defect, vitamin K deficiency, difficult labor delivery. Of course, the treatment is of complications, treatment of hypovolemia, treatment of anemia. We proceed to discuss other types of birth trauma and injuries, and this is a mild subconjunctival hemorrhage. It absorbs spontaneously and it is not harmful, and no need for its treatment. May occur during process of delivery, pressure on the eyes, and there is rupture of these small capillaries in the conjunctiva. Also, there are another types that may result from birth trauma, and these are deeper and more serious and in form of intracranial hemorrhage. The types of intracranial hemorrhage are different depending on their sites or depending on their location. We will not focus on this because it will be talked in another or separate entity or separate lecture. We only will enumerate the types of these intracranial bleeding according to its location: epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intraparenchymal hemorrhage. These types of hemorrhage mostly occur in full-term baby, while preterm baby is liable to have germinal matrix and intraventricular hemorrhage. We finished talking about the cranial injuries. The second type of birth injuries is peripheral nerve injuries. And the most common type of birth injury involving the peripheral nerve is brachial plexus injury, in form of Erb's Duchenne palsy or Klumpke paralysis, depending on its level of involvement. And another type of peripheral nerve injuries is phrenic nerve paralysis. The Erb's palsy involves C5 and C6. It is an adverse condition. It is caused by physical injury and stretching of the nerves during delivery. It is a form of obstetric brachial plexus disorder. Presentation: the infant cannot move the affected shoulder or upper arm, but grasp reflex is intact. And this problem may occur during difficult labor or prolonged labor, when there is excessive pulling on the shoulders, mainly cephalopelvic disproportion, Breech delivery is mostly associated with this, especially when the baby is large for gestational age. Listen to this case presentation. A mother of 32 years old. She is para 2 plus 0. She is presented in the labor. The labor was spontaneous in onset, but occurs 8 days past term. The first stage lasted 11 hours. The second is 2 hours. During birth, the shoulders became severely impacted. The baby's weight is 4.5 kg. Resuscitation was done for him, and he was referred to the NICU, neonatal intensive care unit, for further management. On the next day, on routine examination for this child, the Moro reflex was unilateral. You can see the picture of this Moro reflex. He moved only one hand. He is unable to move the another hand. Look to this. So this is seen in the child. You can describe the findings. The reflex is absent on the affected side. The arm is adducted, internally rotated, and there is pronation of the forearm. This is the position usually seen in a neonate who is suffering from Erb's palsy. So now the diagnosis is easy, and it is easy to mention what is wrong with this baby. He has brachial plexus injury. Which type of brachial plexus injury? We mentioned that we have two types according to presence of a grasp reflex, according to the level. If the grasp reflex is intact, C5 to 6 level is affected, it is called Erb's palsy. If the grasp reflex is absent, the lesion is C7, C8, sometimes T1, and this is called the clamp-key paralysis. This picture shows intact grasp reflex. So we need to examine the reflexes to be sure whether it's Erb's palsy or clamp-key paralysis. So for this baby, we need to do some investigations. What are other investigations we need to do? We need to assess the shoulder and upper limb by X-ray. Of course, we know the cause. Why we send for chest X-ray? Because we need to exclude other conditions that may present with similar findings. It has only unilateral Moro reflex. For example, a fracture clavicle, fracture of the long bones, and shoulder dislocation. What's wrong in this chest X-ray? So see this chest X-ray and find the abnormality. It is very easy for you to find the abnormality. So now we diagnose this patient to have brachial plexus injury. So what is the treatment for this problem? How can we treat this problem? This neonate is in need for physiotherapy, and this physiotherapy to be started in the second week postnatal. Sometimes a multidisciplinary team is needed. Pediatric neurologist, a neurosurgeon, physical therapist, and orthopedic surgeon, especially when the injury is severe and the clamp-key paralysis is occurring. We will continue talking about the previous baby. 4 weeks later, you see this child for follow-up. He looks well, but still he has weakness of the affected limb. Still, the moro is not equal bilaterally. The mother was worried, and she asking you, what is the outcome? What is the prognosis for this problem? So, what will be your answer? What would be your response? So the prognosis depends mainly upon the severity of the baby's injuries. There are cases of different severity. Mild cases may clear up within months, 3 to 6 months. Of course, they need physical therapy. More than 70%, 70 to 80% will clear up within a year, as long as proper and consistent treatment is provided in form of physiotherapy. Of course, the younger the infant is when treatment begins, the better the results are. And one way to determine a positive prognosis is the infant begins to grasp objects or make fists with the hand associated with the affected area during treatment sessions. We also will talk about facial nerve palsy, which is resulting from compression of the facial nerve against the mother's ischial spine or pressure from forceps. It is usually unilateral. The baby will present with facial weakness on crying, and the eye remains open on the affected side, and it is usually transient. We need to put some eye drops, methylcellulose. Rarely nerve pulses may be from damage to the cervical spine, mainly the pathway of the nerve rather than cervical spine injury. And this is a picture of right facial nerve palsy of the newborn. On the affected side, the baby is unable to close the eyelid. Also, there is deviation of the mouth toward the left side, so the lesion is in the right side. We will talk about serious injuries and birth injuries and trauma that may occur during labor, visceral injuries. And the commonest affected organs are liver, spleen, and suprarenal. Sometimes these injuries are mild and may pass asymptomatic, but when it becomes severe, it leads to shock, pallor, and jaundice. The diagnosis of these can be done by ultrasonography. So when we are facing baby with pallor, with abdominal distension, with the history of prolonged and difficult labor, we need to think about visceral injuries, and this baby is in need for doing ultrasound, abdominal ultrasound for him. Another form of birth injuries are skeletal injuries, and the most common bone affected is the clavicle, and there are also other bones like humerus, skull, femur, ribs, and the baby may develop dislocation of the hip and shoulder and epiphyseal separation also. Other types of injuries are muscular injuries, and the most common type of muscular injury is sternomastoid muscle tumor. The baby will have swelling of the lower half of the muscle due to hematoma. Clinically, he will present with hard, painless, non-fluctuating cervical swelling. If it was left without treatment, it may lead to torticollis, and it needs a physiotherapy as a form of treatment. This is the location of sternomastoid muscle mass. Let's hear this case presentation. Previously healthy 3-week-old neonate presented to the neonatal unit for evaluation for left-sided neck swelling, which was noticed during the previous week. On examination, he has a swelling. The size is 2 by 2 centimeter. It is firm, non-tender mass in the lower left neck with no overlying skin changes. There was no obvious limitation in the range of motion. Clinically, the neonate has no fever. He is feeding well, and he was normal on the examination. Prenatal history was not significant. He was delivered by breech presentation. The postpartum history is normal. So, after hearing this scenario, you can guess the cause for this swelling or this mass. And this is picture of this swelling involving the lower part of the neck. This is picture of sternomastoid muscle tumor that may occur bilaterally. And this is the mass 2 weeks after, at 2 weeks of age. Thank you very much for listening, but you can comment on the picture on this slide. The comment was left to you. Thank you.